Welcome, deep divers. Today, we're embarking on a really fascinating deep dive into the often misunderstood world of female reproductive health and common gynecologic disorders. Our mission, as always, is to give you that shortcut to being truly well informed, cutting through complex information, and, unearthing some surprising facts and valuable insights along the way. Get ready to explore.
Absolutely. And what's truly profound here is how exquisitely interconnected the different systems are. I mean, even small hormonal shifts can have this ripple effect across the entire reproductive system. Kind of explains why things can feel so delicate sometimes. Understanding that foundational physiology is, well, it's key to making sense of the various conditions we'll discuss.
Okay, let's unpack this then. Before we delve into specific disorders, we really need a solid grasp of how the menstrual cycle actually works. You described it perfectly, like this meticulously choreographed hormonal dance, a complex conversation happening between the brain, the ovaries, and the uterus. It generally unfolds in two main phases. So first, we have the follicular phase. This typically runs from about day 1, the start of your period, to let's say around day 12. In this phase, estrogen takes center stage. It all kicks off with signals from a part of your brain called the
Right,
hypothalamus.
sending out GnRH.
Exactly, gonadotropin releasing hormone. This GnRH then prompts your pituitary gland to release FSH and LH, which travel down to the ovaries. FSH's job is basically to encourage a group of follicles which contain the eggs to mature. As one dominant follicle grows, it starts producing a lot of estrogen. And this rising estrogen then builds up the lining of the uterus, the endometrium, getting it ready for a potential pregnancy. This is often called the proliferative stage. Now, here's where it gets really interesting, a kind of surprising twist. Usually, rising estrogen inhibits those original signals from the brain and pituitary.
Negative feedback.
Right, preventing new follicles from starting. It's a clever way the body ensures, generally only one egg ripens at a time. Then, around days 12 to 14, we hit the moment of ovulation.
The big event.
Yeah, this is where the plot thickens. That high level of estrogen from the now mature follicle suddenly switches its feedback on the brain and pituitary from negative to positive.
Ah, the switch.
Exactly. This causes a surge in estrogen, FSH, and crucially, this massive spike in LH, the LH surge. This surge is the signal for the mature follicle to rupture and release its egg. Once the egg is released, we move into the luteal phase from about day 14 to day 28. Now progesterone becomes the dominant hormone.
Right.
That same LH surge that triggered ovulation also transforms the empty follicle into something called the corpus luteum.
The yellow body.
Yes, the corpus luteum is like a temporary hormone factory, pumping out both progesterone and some estrogen. This keeps that uterine lining thick and stable, ready for implantation. This is the secretory phase.
And importantly, at this point, estrogen and progesterone switch back to their negative feedback loop on the brain.
Okay, so they're telling the brain, hold off for now.
Exactly. And if that egg isn't fertilized, or if it doesn't implant in the uterine lining, well, the corpus luteum, that temporary factory, starts to break down. This causes a steep drop in both estrogen and progesterone. Now, this raises an important question. Why does this drop in hormones matter so much for the start of the next cycle?
Well, I guess without those hormones, the lining can't be maintained.
Precisely. Without those hormones to support it, the endometrial lining begins to break down and slough off, leading to menstruation, the period. And crucially, as those hormones drop, the negative feedback on GnRH from the hypothalamus subsides.
Ah, so the hold-off signal stops.
Right. This allows those brain signals, the pulsal GnRH, to ramp up again, leading to FSH and LH release, restarting the whole follicle maturation process for the next cycle. What's truly fascinating, too, is that the frequency of these GnRH pulses subtly dictates whether the body favors producing more FSH or LH. Faster pulses favor LH, slower ones favor FSH. It's incredibly fine-tuned.
Wow, so if this is the exquisitely choreographed dance, what happens when someone steps on a toe or, the music skips a beat? What does all this mean for understanding when things go awry? Knowing that hormonal dance is absolutely foundational for understanding common symptoms and these broader categories of gynecologic issues. Let's start with something many women experience: abnormal uterine bleeding, or AUB. This is essentially any bleeding that deviates from what's considered normal for you. Whether it's a volume, how often it occurs, its regularity, or just how long it lasts. And if it's heavy or prolonged, it can even lead to issues like anemia, making you feel tired and weak.
Definitely. And to systematically approach AUB, healthcare providers often use a really helpful framework. It's called POM-COAIN.
Palm Cohen.
Think of it as a clear roadmap for investigation. The polyam part covers structural problems inside the uterus. P is for polyp, those little growths. A is for adenomyosis, where the uterine lining tissue grows into the muscle wall. L is for leiomyoma, which are more commonly known as uterine fibroids, benign muscle growths. And M is for malignancy or hyperplasia, meaning precancerous changes or actual cancer.
Got it. Polyam is structure.
Right. Then the CUN part covers non-structural causes. C is for coagulopathy, issues with blood clotting. O is for ovulatory dysfunction, where that hormonal dance isn't quite right. Polycystic ovary syndrome, PCOS, is a classic example here. E is for endometrial issues, problems specifically with the uterine lining itself. I is for iatrogenic, meaning it's caused by medical treatment or medication, like certain IUDs or anticoagulants. And N is for not otherwise classified, for the causes that don't fit neatly into the other boxes. This gives us a clear roadmap for thinking about the underlying causes.
That's really helpful. Okay, another incredibly common complaint is painful periods, medically known as dysmenorrhea. And this isn't just like minor discomfort, it's pain severe enough to interfere with your normal daily activities.
That's the key distinction.
We generally categorize it into two types, right? Primary and secondary dysmenorrhea.
Exactly. Primary dysmenorrhea is often due to an overproduction of prostaglandins. These are hormone-like substances that cause the uterine muscle to contract more intensely, sometimes reducing blood flow. This typically starts maybe a year or two after a young woman first gets her period, often in teenagers. The good news is it often improves as she gets older or sometimes after childbirth.
Okay, so that's primary. What about secondary?
Secondary dysmenorrhea, however, is caused by an underlying pelvic or uterine condition, something structural or pathological. We often see it with conditions like endometriosis, pelvic inflammatory disease, PID, adenomyosis, or those uterine fibroids, the leiomyomas we just mentioned.
So something else is causing the pain.
Right. This type of pain often begins later in life, usually after age 25. It can sometimes be localized more to one side, and concerningly, it often has a tendency to worsen over time, unlike primary dysmenorrhea.
That worsening pattern is a key difference. And then we have premenstrual syndrome, or PMS, and its more severe counterpart, PMDD.
Premenstrual dysphoric disorder, yeah.
PMS is that familiar cluster of physical, behavioral, and mood changes that cyclically pop up during the luteal phase, that second half of your menstrual cycle after ovulation.
And PMDD is essentially PMS amplified. The symptoms are so severe that they significantly impact daily functioning. Anger, irritability, and this really intense internal tension are often particularly prominent. It's actually a diagnosable condition in the DSM, the Diagnostic Manual, with specific criteria.
Okay, so what kind of symptoms are we talking about for both?
Well, both PMS and PMDD can manifest physically, things like abdominal bloating, fatigue, breast tenderness or swelling, maybe some weight gain, headaches.
Yeah.
Emotionally, you might experience irritability, tension, feelings of depression or anxiety, sometimes even hostility. And behaviorally, things like intense food cravings or difficulty concentrating are common.
And it's the timing that's key for diagnosis, right?
Absolutely. For a diagnosis, these symptoms need to consistently occur, say, 1 to 2 weeks before your period starts, and then they need to resolve within a few days of your period actually beginning. Plus, there should be at least 7 symptom-free days in the first half of the cycle, the follicular phase. A symptom diary kept over a couple of cycles is often the best way to confirm this pattern.
Makes sense. And how is it managed?
Management usually starts with lifestyle modifications, thinking about stress reduction techniques, regular exercise, maybe some dietary adjustments like limiting salt, sugar, caffeine, over-the-counter options like NSAIDs for pain, or even certain vitamins like B6 and E might be suggested by a provider.
What about when it's more severe, like PMDD?
Yeah, for emotional symptoms that are significantly impacting life, cognitive behavioral therapy, CBT, can be really effective. And selective serotonin reuptake inhibitors, SSRIs, common antidepressants like fluoxetine, sertraline, citalopram, are often considered first-line medication options. They can be taken just during the luteal phase or continuously. Certain oral contraceptives, particularly those containing a specific progestin called drospirenone, can also be very helpful, especially for PMDD.
And in really tough cases.
In very challenging refractory cases, GnRH agonist therapy, which essentially induces a temporary menopause state, might be considered, but that's usually a last resort due to side effects.
Okay, that's a comprehensive approach. Now let's take a deeper dive into some specific conditions you might hear about frequently. First up are leiomyomas, better known to most of us as uterine fibroids.
Right. Very common.
These are benign, so non-cancerous growths of the uterine smooth muscle. And surprisingly, they are the most common benign gynecologic tumor out there.
That's true.
What's truly interesting, though, is that only about 20 to 25% of women with fibroids ever actually experience symptoms. Many don't even know they have them.
Exactly. Their growth is heavily influenced by estrogen. That's why they tend to increase in size during the menstrual cycle or during pregnancy when estrogen is high, and often shrink after menopause when estrogen levels drop.
And who's most at risk?
Well, increasing age, especially being over 35, plays a role. They're also significantly more common, about 5 times more common, in black women, and never having given birth, or nulliparity, is a risk factor, whereas previous pregnancies actually seem to decrease the risk somewhat.
Interesting. And when symptoms do appear, what are they typically?
Commonly, abnormal uterine bleeding is a big one. And here's a key insight. The location of the fibroid often matters more than the size. A small fibroid located right under the uterine lining, called a submucosal myoma, can cause much more significant bleeding than a larger fibroid buried deep in the muscle wall.
That challenges the assumption that bigger is always worse.
It does. Other symptoms can include pelvic pain or a feeling of pressure, like on the bladder or rectum, and they can sometimes impact fertility by interfering with implantation or possibly increasing miscarriage risk.
How are they usually diagnosed?
Diagnosis is typically made quite easily with a transvaginal ultrasound. It's very effective at visualizing them.
And management. It seems like there'd be a range of options.
There really is.
Yeah.
And management truly hinges on what you want, especially considering your fertility goals and symptom severity. For asymptomatic cases, simple observation, just keeping an eye on things, is often enough. Non-surgical options include things like hormone-containing oral contraceptives or a progesterone-releasing IUD like the LNG IUD to manage bleeding. NSAIDs can help with pain. Sometimes GnRH analogs are used temporarily to shrink the tumors, often before surgery to make it easier.
And surgical options.
Surgical options range from a myomectomy where only the fibroids are removed, preserving the uterus and fertility, all the way to a hysterectomy, which is the definitive removal of the uterus.
So it seems like managing fibroids really depends on what you want in your fertility goal.
Absolutely. It's a very personalized decision-making process.
That distinction about location versus size is a great insight.
Okay, next we have adenomyosis. This is a condition where the endometrial tissue, which normally lines the uterus, well, it starts to grow within the muscular wall of the uterus itself, the myometrium, into the muscle.
It often shows up later in a woman's reproductive years, typically between, say, 35 and 50.
That's right. And the problem with this ectopic or misplaced tissue is that it induces a kind of hypertrophy and hyperplasia, basically, an abnormal thickening and enlargement of the surrounding uterine muscle. This leads to a diffusely enlarged uterus that doctors might describe as globular or sometimes feeling boggy or soft on pelvic examination.
And symptoms.
Well, like fibroids, many women with adenomyosis are actually asymptomatic. But for those who do experience symptoms, they often include progressively worsening heavy or prolonged bleeding, menorrhagia, and secondary dysmenorrhea, those painful periods that started later in life and seem to get worse.
How is it diagnosed? It sounds a bit trickier than fibroids.
It can be. Diagnosis is often made clinically, sometimes by ruling out other conditions. Transvaginal ultrasound is usually the initial imaging choice, and sometimes MRI can be helpful. But definitive diagnosis technically requires examining the uterus after hysterectomy.
Wow, okay, so management.
Management for adenomyosis can involve conservative options aimed at symptom control, like a progesterone-releasing IUD, which can significantly reduce bleeding and pain for many. But for definitive treatment, particularly if symptoms are severe and childbearing is complete, hysterectomy is the only cure.
What's fascinating here is how the presence of that misplaced tissue actually causes the uterus itself to enlarge and become tender.
It really is. The uterus reacts to that tissue being where it shouldn't be.
And then there's endometriosis, a condition that affects up to 10% of reproductive age women. This is where endometrial tissue, again, that same lining tissue, implants and grows outside the uterus altogether.
Right. Elsewhere in the pelvis, usually.
It's also the most common gynecologic cause of secondary dysmenorrhea, that later onset period pain.
Yes, it is. This ectopic tissue can be found in various places. Most commonly, it's on the ovaries. That's over 55% of cases. It can also be found in the cul-de-sacs, which are just these pockets of space behind and around the uterus and on the ligaments that support the uterus, like the uterosacral ligaments.
And why does this cause problems?
Well, the core issue is that this misplaced tissue still responds to your cyclical hormonal changes, particularly estrogen. So it grows and bleeds, just like your uterine lining does each month. But because the blood has nowhere to easily exit the body, it causes an intense inflammatory response, leading to pain, scarring, and adhesions over time.
Ah, inflammation and scarring. That makes sense.
Exactly. This is why symptoms typically lessen during pregnancy and usually resolve after menopause, when those cyclical hormonal fluctuations and estrogen levels drop off.
What are the classic signs?
The classic triad of symptoms includes cyclic premenstrual pelvic pain, pain that ramps up before the period; dysmenorrhea, painful periods that often worsen over time; and deep thrust, painful intercourse, or dyspareunia.
Okay, the triad. Are there other symptoms?
Yes, other symptoms can include abnormal bleeding, painful bowel movements or urination, especially around the period, and there's a very strong association with infertility. It's estimated to affect somewhere between 30 to almost 50% of women struggling with infertility.
Wow, that's a high percentage. How is it diagnosed for sure?
Diagnosis is often suspected clinically based on those symptoms. However, the definitive way to diagnose endometriosis is through laparoscopy, minimally invasive surgery, where a camera is inserted into the abdomen and actually seeing the implants and taking biopsies. During surgery, doctors might find characteristic lesions or sometimes chocolate cysts on the ovaries, which are cysts filled with old dark blood. They're called endometriomas.
Chocolate cyst, okay. And management, similar range to fibroids.
Sort of, but focus more on managing pain and inflammation and addressing fertility if desired. Management can range from just expectant management or using NSAIDs for mild pain to hormonal therapies that suppress ovulation. Combined oral contraceptives or progestins are often first-line treatments. They help by reducing the hormonal stimulation of the implants. For more severe symptoms, GnRH agonists or antagonists might be used to create that temporary low estrogen state.
And surgeries.
Surgical options include conservative laparoscopy, where the surgeon removes or destroys the endometrial implants and scar tissue while preserving the uterus and ovaries, primarily for pain relief and sometimes to improve fertility. Or, for severe cases where fertility is not desired, a definitive hysterectomy, often with removal of the ovaries and fallopian tubes, bilateral salpingo-oophorectomy, might be considered.
If we connect this to the bigger picture, it's really about this misplaced tissue continuing its hormonal dance, causing inflammation and significant pain wherever it happens to be located.
That's the essence of it, yes.
Moving on slightly, let's talk about polyps, essentially, overgrowths of tissue. We should probably differentiate between endometrial polyps and cervical polyps.
Good idea. They're different locations. Endometrial polyps are overgrowths of the uterine lining, the endometrium. They're actually more common in postmenopausal women. Like fibroids, their growth can be estrogen dependent. They are frequently asymptomatic, but when they do cause symptoms, it's often irregular vaginal bleeding or spotting.
Okay, those are inside the uterus. What about cervical polyps?
Cervical polyps are growths on the surface of the cervix itself, the lower part of the uterus that extends into the vagina. They're common during reproductive years, especially after age 40. They are also often asymptomatic, but can cause irregular bleeding, spotting between periods, or sometimes bleeding after intercourse.
So, both can cause bleeding. This raises an important question. Why is it so important to check these out, even if they're usually benign?
That's crucial. While the vast majority of both endometrial and cervical polyps are benign, a definitive diagnosis always requires removing the polyp, polypectomy, and sending it for histologic examination, basically looking at it under a microscope. This is essential to rule out malignancy or cancer. While rare, the risk of finding cancer or precancerous changes within a polyp is higher, particularly for endometrial polyps in postmenopausal women who experience bleeding.
So don't ignore bleeding, get it checked.
Absolutely. Removal is typical management and necessary for that definitive diagnosis.
Let's transition now to understanding amenorrhea, which simply means the absence of menstruation, no periods. We differentiate between two main types, right? Primary and secondary.
Correct.
Primary amenorrhea is when a young woman hasn't started her period by age 15, especially if other signs of puberty like breast development are present, or by age 13 if those secondary sex characteristics like breast development or pubic hair are absent.
Right. The timeline depends on other development.
And secondary amenorrhea is when periods stop for more than 3 months in someone who previously had regular cycles, or for more than 6 months if their cycles were previously irregular.
Exactly. And by far the most common cause of secondary amenorrhea is pregnancy. So that's always the very first thing to check with a pregnancy test, HCG.
Always rule out pregnancy first.
Always. After that, the diagnostic journey can be quite systematic and detailed. It usually involves blood tests, checking FSH to assess ovarian function, TSH for thyroid issues, and prolactin levels, as high prolactin can suppress periods.
Okay, so what might those tests tell you?
Well, for example, in primary amenorrhea, if a young woman has increased FSH levels but very little breast development, doctors might consider a karyotype, a genetic test, looking for conditions like Turner syndrome. If FSH is normal, but an ultrasound shows there's no uterus, then conditions like malarianogenesis, where the uterus and upper vagina simply didn't form properly, or androgen insensitivity syndrome might be considered.
What's androgen insensitivity?
That's a genetic condition where someone is genetically male, 46XY, but their body doesn't respond to male hormones, androgens, so they develop externally as female but don't have a uterus and have internal testes. Testosterone levels would be in the male range.
Fascinating. What if the uterus is there?
If FSH is normal, breast development is present, and maybe an ultrasound shows accumulated blood, hematometra or hematoculpos, it suggests an obstructed outflow tract. Something is blocking the blood from coming out, like a transverse vaginal septum or an imperforate hymen.
A blockage.
Right. And if FSH is low or normal, and a uterus is present, then the causes could range from constitutional delay of puberty, maybe a congenital GnRH deficiency affecting those brain signals.
Hmm.
Or it could be causes more typical of secondary amenorrhea, like functional hypothalamic amenorrhea.
What's that functional hypothalamic?
That's when the hypothalamus slows or stops releasing GnRH due to stressors like excessive exercise, low body weight, or significant psychological stress. It's often seen in the female athlete triad.
Ah, the triad. Hypothalamic amenorrhea, low energy availability, often from disordered eating, and decreased bone mineral density or osteoporosis.
Exactly. The body basically shuts down reproduction to conserve energy.
What's absolutely essential here, it seems, is that systematic workup. Using the hormone tests like FSH, prolactin, TSH, combined with imaging like ultrasound to check for the uterus, to really pinpoint the specific cause. It's not just a guessing game.
Absolutely not. It requires careful investigation.
Okay, moving to endometrial health specifically now. We have endometrial hyperplasia and endometrial cancer. Endometrial hyperplasia is when the cells of the uterine lining, the endometrium, grow abnormally thick, and it can be a precursor, a warning sign for endometrial cancer.
That's right. Hyperplasia means too much growth.
And endometrial cancer itself is the most common gynecologic malignancy in the U.S., primarily affecting women after menopause.
Yes, though it can occur in younger women, it's much more common postmenopausally. And the primary risk factor for both hyperplasia and cancer is prolonged unopposed estrogen.
Unopposed meaning not balanced by progesterone.
Exactly. Estrogen stimulates the endometrial lining to grow, while progesterone matures it and keeps the growth in check. If you have estrogen stimulation without enough progesterone counterbalancing it, the lining can overgrow.
Where does this unopposed estrogen come from?
It often happens in conditions where ovulation doesn't occur regularly, like polycystic ovary syndrome, PCOS, because without ovulation, there's no corpus luteum to produce progesterone. It can also happen in women taking estrogen-only hormone therapy if they still have a uterus. Obesity is also a major risk factor because fat cells can convert other hormones into estrogen.
Ah, okay. Even certain medications.
Yes, specifically tamoxifen, which we'll talk more about later. While it blocks estrogen in the breast, it acts like estrogen on the endometrium, increasing the risk of both hyperplasia and cancer.
So what's the biggest red flag for these conditions?
Abnormal uterine bleeding, especially, and this is critical, any bleeding after menopause. Postmenopausal bleeding is considered endometrial cancer until proven otherwise and needs immediate evaluation. In premenopausal women, it might present as heavy, prolonged, or irregular bleeding.
If we connect this to the bigger picture, any postmenopausal bleeding must be promptly investigated by a healthcare provider. No waiting.
Absolutely essential. Diagnosis typically starts on the transvaginal ultrasound. They'll look for a thickened endometrial stripe, the lining. A thickness over 4 millimeters in a postmenopausal woman is suspicious. But the definitive diagnosis comes from an endometrial biopsy, taking a small sample of the lining tissue to examine under the microscope.
And treatment, does it depend on whether it's hyperplasia or cancer?
Yes. For hyperplasia without atypical cells, meaning the cells look abnormal but not yet cancerous, management might involve progestin therapy, using progesterone-like medication, to counteract the estrogen effect and thin the lining. This can often reverse the hyperplasia. However, for hyperplasia with atypical cells, the risk of underlying cancer is high, so hysterectomy is usually recommended, unless a woman strongly desires future fertility, in which case high-dose progestin therapy with very close monitoring might be an option.
And for actual cancer?
For endometrial cancer, management is primarily surgical. The standard is a total hysterectomy with bilateral salpingo-oophorectomy, TAH-BSO, removing the uterus, cervix, fallopian tubes, and ovaries. Lymph node assessment might also be done. Depending on the stage and grade of the cancer found after surgery, radiation or chemotherapy might be recommended.
But there's some good news here, right?
Yes, the good news is that endometrial cancer is often diagnosed at an early stage because that postmenopausal bleeding usually prompts women to seek care quickly. When caught early, it's one of the most curable gynecologic cancers.
That's reassuring. Okay, let's turn our attention now to navigating life stages, specifically menopause and beyond. Menopause is officially defined as the cessation of your period for more than 1 year, 12 consecutive months with no period.
Right. It marks the end of reproductive capability.
And it's due to the natural decline and loss of ovarian function, which means significantly decreased estrogen and progesterone production by the ovaries. In the US, the average age for this is somewhere between 50 and 52 years. And that transitional period leading up to it, with all the fluctuating hormones and early symptoms, is what we call perimenopause.
Correct. Perimenopause can last for several years before the final menstrual period. And the clinical manifestations of this drop in estrogen are incredibly diverse. They affect almost every system in the body.
What are the most common things women notice?
Well, the most common symptom, especially during perimenopause, is vasomotor instability. That means those familiar hot flashes, night sweats, sometimes heart palpitations. Hot flashes are really the hallmark symptom for many.
Right, the sudden feeling of heat.
Exactly. Other impacts include sleep disturbances, often related to the night sweats, but sometimes independent. Mood changes are common, increased irritability, anxiety, or depressive symptoms. You might also notice changes to skin, nails, and hair skin becoming drier, hair thinning. And what's often less discussed, but very important long-term, is the increased risk for cardiovascular events, high cholesterol, hyperlipidemia, and bone loss leading to osteoporosis.
How is menopause confirmed diagnostically?
Clinically, it's usually based on that 12 months of no periods in the right age range. But if needed, a blood test for FSH, follicle-stimulating hormone, can be helpful. An FSH level consistently greater than 30 IU/ml is indicative of ovarian failure and suggestive of menopause. It's considered the most sensitive initial diagnostic test if confirmation is needed.
Okay. Building on that, related to the low estrogen, we have genitourinary syndrome of menopause, or GSM. You might also hear it called vulvovaginal atrophy.
Yes, GSM is a more current and encompassing term.
And this condition is directly linked to those lower estrogen levels during menopause, causing various changes in the vulva, the vagina, the urethra, and the bladder. Tissues in that whole area are very estrogen sensitive.
Precisely. Symptoms often include vulvovaginal dryness, which can lead to dyspareunia, painful intercourse due to decreased natural lubrication. Women might also experience vaginal inflammation, leading to burning, itching, or general irritation. And interestingly, recurrent urinary tract infections, UTIs, can become more common.
Why UTIs?
Because the lack of estrogen changes the vaginal environment. The pH increases, becoming less acidic, and the normal balance of bacteria can shift, making it easier for UTI-causing bacteria to ascend into the bladder.
Ah, okay. This raises an important concern. Why are topical treatments often preferred for managing GSM?
That's a great point. Topical vaginal estrogens available as creams, vaginal tablets, or rings that are inserted directly into the vagina are typically the safest and most effective medical therapy, specifically for GSM symptoms. They work directly on the affected tissues, restoring moisture and elasticity. And because they're applied locally, there's very little systemic absorption into the bloodstream.
So fewer risks compared to taking estrogen pills.
Exactly. This translates to far fewer systemic risks compared to oral hormone therapy, making them a very safe option for most women experiencing only genitourinary symptoms. Non-hormonal vaginal moisturizers and lubricants are also important first-line options.
And of course, when we talk about menopause management more broadly, hormone replacement therapy, or HRT, is always a major topic. It feels like the advice on this has changed over the years.
It absolutely has. HRT, or more accurately, menopausal hormone therapy, MHT, can be indicated for managing moderate to severe menopausal symptoms, particularly those vasomotor symptoms like hot flashes and night sweats, especially in healthy women who are relatively young, usually under 60 years old or within 10 years of menopause onset. It's also effective for preventing osteoporosis and fractures. However, it's crucial to understand that the science around MHT has evolved dramatically, especially since the Women's Health Initiative WHI study results came out in the early 2000s.
Right. That study caused a big shift.
It did. The biggest insight now isn't just a simple list of pros and cons, but understanding that what was once almost a blanket recommendation is now understood to be a highly individualized decision. The timing of when a woman starts MHT relative to her menopause onset, her age, her specific symptoms, and her individual risk factors for things like blood clots, heart disease, and breast cancer are all paramount.
So what are the main risks we need to be aware of?
Risks associated with MHT include an increased risk of venous thromboembolism, blood clots like DVT, or pulmonary embolism. There's also an increased risk of gallstones. Critically, there's an increased risk of endometrial cancer if estrogen-only therapy is used in women who still have a uterus. That's why progesterone, or a synthetic version, must always be added to protect the endometrium in those women.
Estrogen plus progestogen if you have a uterus, estrogen only if you don't.
Correct. The potential increased risk of breast cancer with combined estrogen-progestogen therapy is still a complex and somewhat controversial area, though risk seems related to duration of use. And there's a potential increased risk of coronary artery disease, heart attack, and stroke, particularly if MHT is initiated in older women many years past menopause onset. The timing hypothesis suggests earlier initiation might be safer or even beneficial for the heart, but later initiation seems riskier.
So who definitely should not take MHT? What are the contraindications?
Key contraindications include a personal history of or high risk for cardiovascular disease or thromboembolic disease, like DVT/TBE or stroke. Also a history of estrogen-dependent cancers, most notably breast cancer or endometrial cancer. Other reasons not to use it would be any unexplained vaginal bleeding, which needs investigation first, severe active liver dysfunction, or uncontrolled severe hypertension.
Okay, so if we connect this to the bigger picture, the decision for MHT is a very careful balance of individual risks versus potential benefits, always made in close discussion with a healthcare provider who really understands your unique health profile and history.
Precisely. It's not a one-size-fits-all decision anymore.
That's a crucial point about individualized care. Speaking of targeted approaches, we also have selective estrogen receptor modulators, or SERMs. Tamoxifen and raloxifene are two examples. These are interesting medications because they act differently depending on the tissue they're in, almost like a master key that unlocks different responses in different rooms of the body.
That's a great analogy. They do indeed have mixed agonist, estrogen-like, and antagonist, estrogen-blocking effects in different tissues. Let's contrast tamoxifen and raloxifene specifically, as they are commonly discussed. Tamoxifen acts as an estrogen antagonist in the breast tissue. It blocks the estrogen's effects there, which is why it's famously used for treating and preventing estrogen receptor-positive breast cancer. But crucially, it acts as an estrogen agonist, meaning it mimics estrogen's effects in other tissues, including the endometrium, bone, and the blood clotting system.
So agonist in the uterus, that's why it increases endometrial cancer risk.
Exactly. That agonist effect on the endometrium can lead to endometrial hyperplasia and cancer. However, its agonist effect on bone is beneficial, helping to prevent osteoporosis. Its effect on clotting factors increases the risk of blood clots, similar to estrogen.
Okay, so tamoxifen, bad for uterus, good for bone, blocks breast estrogen. What about raloxifene?
Raloxifene is different. It's also an estrogen agonist in the bone, so it's also used for preventing and treating osteoporosis in postmenopausal women. And it has some beneficial effects on lipid profiles. But importantly, it acts as an estrogen antagonist in both the breast and the endometrium.
Ah, so it doesn't stimulate the uterine lining.
Correct. This is a key difference. Raloxifene does not increase endometrial cancer risk, and it also reduces the risk of invasive breast cancer. It's primarily used for osteoporosis and breast cancer prevention in postmenopausal women who are at high risk.
So raloxifene relaxes the uterus by not stimulating it, while tamoxifen can be potentially toxic to it by promoting growth. That's a helpful mnemonic, a good way to remember the key difference when thinking about their uterine impact.
That works. It highlights the main distinction in their endometrial effects.
Okay, now let's briefly touch on just a couple of other important conditions you might encounter. First, endometritis. This sounds like endometriosis, but it's different, right?
Very different. Endometriosis is misplaced tissue. Endometritis is an infection or inflammation of the endometrium, the uterine lining. Specifically, when we talk about it clinically, we often mean infection of the decidua, which is the specialized uterine lining during pregnancy and postpartum.
Ah, so related to pregnancy or childbirth?
Often, yes. It's typically a polymicrobial infection, meaning multiple types of bacteria are involved. And the single biggest risk factor for developing postpartum endometritis is having a cesarean section. The risk is even higher if the C-section is performed after labor has already started and the membranes have ruptured.
Makes sense. More exposure to bacteria. How does it present?
The diagnosis is mainly clinical. Usually, a woman develops symptoms like fever, uterine tenderness, pain when the uterus is palpated, and sometimes foul-smelling or purulent vaginal discharge, lochia, a few days after childbirth or a C-section.
And treatment.
Management involves broad-spectrum antibiotics, given intravenously initially. A common combination, particularly for post-C-section cases, is clindamycin plus gentamicin, as it covers the likely range of bacteria. A key preventative strategy, of course, is giving prophylactic antibiotics, usually a single dose of a cephalosporin like cefazolin, just before starting a C-section. That significantly reduces the risk.
Good to know. Okay, finally, let's talk about uterine prolapse. This is when the uterus essentially herniates or drops down into, or even sometimes completely out of the vagina.
Correct. It happens due to weakening of the pelvic support structures, the muscles, ligaments, and connective tissues that normally hold the uterus and other pelvic organs in place.
What causes that weakening?
The most common cause is damage sustained during childbirth, especially multiple vaginal deliveries or delivery of a large baby, or prolonged pushing. Other factors include aging, menopause, due to lower estrogen affecting tissue strength, chronic straining, like with chronic constipation or cough, obesity, and sometimes previous pelvic surgery.
What does it feel like for someone experiencing it?
Clinically, women might describe a sensation of pelvic pressure or heaviness, a feeling that something is falling out of the vagina, sometimes low back pain. They might also experience urinary symptoms like incontinence or difficulty emptying the bladder, or bowel symptoms like constipation or difficulty evacuating. Sometimes they can actually feel or see a bulge at or beyond the vaginal opening.
Is it graded somehow?
Yes, prolapse is typically graded on a scale from 0, no prolapse, to 4, complete eversion, where the entire uterus is outside the vagina. It can also happen alongside other forms of pelvic organ prolapse, like a cystocele, where the bladder bulges into the front wall of the vagina, or a rectocele, where the rectum bulges into the back wall.
And how is it managed?
Management depends on the severity of the prolapse, the symptoms it's causing, the woman's age and health, and her preferences. Conservative options are often tried first. These include pelvic floor muscle exercises, like Kegel exercises, to strengthen the support muscles. Lifestyle changes like weight loss or managing constipation can help. A vaginal pessary can also be used.
What's a pessary?
A pessary is a removable device, usually made of silicone, that's inserted into the vagina to physically support the uterus and hold it in place. They come in various shapes and sizes.
And if those don't work?
If conservative measures fail or the prolapse is severe, surgical options can be considered. Surgery aims to repair the weakened supports. This might involve a hysterectomy, removing the prolapsed uterus, along with suspension procedures to support the top of the vagina, or there are also uterus-sparing surgical techniques available for women who wish to retain their uterus.
Wow, we've really navigated a tremendous amount of ground today. I mean, from the meticulous dance of the menstrual cycle itself to understanding common symptoms like abnormal bleeding and pain, their broad categories using frameworks like Palm to Cohen, and then taking these really deep dives into specific conditions like fibroids, adenomyosis, endometriosis, even polyps.
Yeah, a lot of oocyst conditions.
Right, and then amenorrhea, hyperplasia, cancer, and the complexities of menopause, GSM, and HRT decisions, plus SERMs and even things like endometritis and prolapse is a huge landscape.
It really is. And I think we've seen how conditions like, say, fibroids, endometriosis, and even menopause, while they are incredibly common, each have their own unique characteristics and really diverse management approaches. Understanding the underlying physiology, that hormonal dance we started with, truly helps make sense of the symptoms and the rationale behind the various treatment options. If we connect this to the bigger picture, it's really about empowering you, the listener, with a deeper, more nuanced understanding of female reproductive health.
Absolutely. So the next time you hear about these conditions, or maybe even discuss them with your own healthcare provider, hopefully you'll feel armed with the insights we've shared today. And perhaps it raises an important question for you personally. How will this understanding change how you approach discussions about your own health, or maybe the health of those you care about? It might just give you a new perspective on these incredibly common and impactful conditions. Thank you so much for joining us on this deep dive. Until next time, stay curious.